Hello, everyone, and thank you for joining us on this episode of the Akal and Koka Report. Our guest today is Peter McCullough, who is a consultant cardiologist and vice chair of internal medicine at Baylor University Medical Center in Dallas, Texas. He's a principal faculty in internal medicine for the Texas A&M University Health Sciences Center. Dr. McCullough completed his medical degree as an Alpha Omega Alpha graduate from the University of Texas Southwestern Medical School in Dallas. He went on to complete his internal medicine residency at the University of Washington in Seattle, and then a cardiology fellowship, including service as chief fellow at William Beaumont Hospital. And then he obtained a master's degree in public health at the University of Michigan. Dr. McCullough is an internationally recognized authority on the role of chronic kidney disease as a cardiovascular risk state, with more than 1,000 publications and more than 500 citations in the National Library of Medicine. His works have appeared in the New England Journal of Medicine, the Journal of the American Medical Association, Lancet, and other top-tier journals worldwide. He is the co-editor of Reviews in Cardiovascular Medicines and associate editor of the American Journal of Cardiology and Cardio-Renal Medicine. He serves on the editorial boards of multiple specialty journals and has made presentations on the advancement of medicine across the world, and has been invited to give lectures at the New York Academy of Sciences, the National Institutes of Health, the US Food and Drug Administration, the European Medicines Agencies, and the US Congressional Oversight Panel. However, we are not here to discuss the cardiorenal syndrome with Dr. McCullough, nor his many illustrious achievements in cardiology, but rather to have him tell us about an article on the outpatient treatment of COVID-19, of which he is first author. The paper is titled Pathophysiological Basis and Rationale for Early Outpatient Treatment of SARS-CoV-2 Infection, and it was published in the American Journal of Medicine online on August 6, 2020. Dr. McCullough, welcome to the show.
Thank you, Dr. Akkad, and let me state that the opinions I'll express today are my own and not necessarily those of my institutions.
Understood. Let's start by this is a paper that has many authors. I mean, I'm glancing at it, maybe 20 or so authors from around the world. But it's not a typical guideline paper that you see that is sponsored by the American Heart Association or kind of a formal organization. How did the authors come together to write this advice on how to treat outpatient COVID?
Well, as a medical community, I think we all felt stormed by the SARS-CoV-2 virus outbreak and the global pandemic. And we're witnessing millions of hospitalizations and hundreds of thousands of deaths in many countries, including our own. And we started looking at the data very carefully, not only in our institution, but in a whole variety of collaborations, including one that we had formed with Italy through the Coracle Registry. And by June of 2020, we felt we had a pretty good handle on what was emerging in terms of the outpatient treatment of early COVID-19 infection. And we felt that there was a great unmet need. We had heard a lot about contagion control or spread of the virus. We had heard some about late stage treatments and what treatments could be tried in the hospital. And then we are given great hope for a vaccine, but the missing pillar of pandemic response was early ambulatory treatment. And we looked in the literature at that time, there wasn't a single paper recommending an approach to treatment, let alone guidelines.
Very good. But to be clear, so are these colleagues that you had relationships with from before, from your prior work in the cardiorenal world, or how did these connections develop? And maybe some of them you knew, and some others you met in the course of preparing for this article?
Right. It started by several Italian colleagues reaching back to us regarding what was going on in Italy before things really started to get severe in the United States. And we embarked on a whole series of analyses with respect to use of ACE inhibitors, how we could predict thromboembolic complications, what the rates were for those who needed oxygen, the mechanical ventilator. And there became a relatively unified feeling that if we don't get some approach to early outpatient treatment, that the hospital was not an adequate safety net, and clearly hospitalization was not going to prevent the next hospitalization. So we formed a collaborative. We needed key people that we brought in. We needed an ophthalmologist to opine on the safety of some of the drugs from an ocular perspective. We needed a cardiac electrophysiologist, again, with respect to safety. And then we had notable institutions in the United States, including Yale, Emory, Baylor, some top institutions in Italy where I had done some work, the internal medicine group at Siena as an example. So we all came together and had to move quickly in terms of synthesizing the literature and agreeing upon approach.
Okay. Do you want to walk us through a little bit the outline of your findings and perhaps, I mean, you'll walk us through, and then I'll ask you how much of this is mainly literature review or how much of it is personal experience, either from you or other of the co-authors?
Well, most of the authors, not all, but I would say most, 90%, had personal experience in treating COVID-19, including myself. In addition, we were aware of really initially with respect to pandemic response, we end up having observational studies and then small randomized trials and moving forward, realizing that the standard for chronic disease was not going to apply, meaning the standard for a chronic disease therapy is proven efficacy and safety of a new drug and then regulatory approval. We recognized that in a matter of days or weeks, that was never going to happen. So we were much more interested in identifying drugs, available drugs that had a reasonable probability of success and a well-characterized safety profile. Those were the ground rules. Those are the new ground rules, honestly, that ultimately any guidelines panel will need to follow if they are going to help people with this illness. So when we surveyed the literature and began to put it together, I think there was about 50,000 papers published on COVID-19, but this giant omission in terms of what to do. And so we borrowed somewhat from what was going on in the hospital. And what was going on in hospital patients was an attempt at some agents to reduce viral replication. And what we knew from preclinical studies and early clinical studies is that zinc sulfate could play a role, particularly in other coronaviruses. There was a building literature of the use of hydroxychloroquine. So we came up with the idea from prospective studies of combining hydroxychloroquine with azithromycin or doxycycline. And then in a modified version of the algorithm, which will appear very shortly in the literature, a second option we put forward, and that was the use of ivermectin, an anti-parasitic agent, which impairs nuclear entry of the SARS-CoV-2 virus, again, plus azithromycin or doxycycline. Then the last option was really for outside the United States, and that was the use of an oral polymerase inhibitor, favipiravir, which is approved for use in treating SARS-CoV-2 in over 30 countries worldwide, not used in the United States. So the hydroxychloroquine-based approach, ivermectin-based approach, or favipiravir, the addition of the antibiotic, azithromycin or doxycycline, the rationale for that has a mild antiviral effect, but also could treat secondary forms of infection in the tracheobronchial tree. So once we had that antiviral box complete, then the next issue was really what to do after that. And the agreement was, based on what we saw emerging from trials, was that on day 5 of the illness, or if any pulmonary symptoms developed, to start corticosteroids. Now we knew at the time, we just had the preprint from the recovery trial, the dexamethasone study. Now that was a late stage study in the hospital using a somewhat odd dose of a steroid, dexamethasone, 6 milligrams a day, PO or IM. And while it showed a statistically significant reduction in mortality, it really was not very satisfactory. In fact, the mortality group in the dexamethasone group was 22.9%. We felt that was unacceptable. We felt a much better choice of the steroid was prednisone, which we use commonly in asthma and allergic pneumonitis. and we felt comfortable with a dose of about 1 milligram per kilogram for 5 days with no taper. And again, that was basically based on clinical judgment. In that steroid box, we also included the possibility of adding colchicine, although not a steroid, an inhibitor of microtubular assembly, because we're aware of a large clinical trial underway called COL-Corona by the Montreal Heart Institute. And we're also aware of the Greco trial that had already completed with colchicine that showed some signal of efficacy. And then the final issue on therapy was how to address this pathobiological microthrombosis, or even overt venous and arterial thrombosis. And there we had observational data that patients who do receive antithrombotic treatment, sometimes just out of necessity in the hospital, appear to do better than those who don't. So the use of low molecular heparin or the oral novel anticoagulants was thought to be reasonable for us. Now, the duration of treatment for all three of those boxes, off-target antivirals, corticosteroids, and antithrombotics, we thought the shortest course that anyone had expertise with was about 5 days, and the longest course would be about 30 days. And we recognize in older patients and at risk, COVID-19 can be a very long illness, much longer than I think what lay people understand. The average hospital stay in US hospitals can be several weeks now. Outside the United States can even be longer. Now, we thought the algorithm was appropriate for patients over age 50 or those who had one or more comorbidity, heart, lung, or kidney disease, those patients with diabetes, obesity, or current or past cancer. If patients were over age 50 and had those comorbidities, in fact, they probably should receive all three of those major domains of treatment: off-target antivirals, corticosteroids, and antithrombotics. Those individuals who didn't risk stratify out so strongly that they could actually have some graduated use of in this sequential stage program. Patients under age 50, no medical problems, the committee felt really no treatment was needed. And so that's good news for younger individuals who otherwise are healthy. The data suggests they simply can complete a self-quarantine and return to their usual activities.
Okay. So this is very much old-fashioned bedside medicine, go by the bootstrap, bootstrapping, so to speak. And as you said at the beginning, it's very difficult in this particular window to demonstrate, efficacy with the standard expectation of clinical trials and whatnot, just because in the vast majority of the cases, it's a self-limited illness, right? And so people do better, but that can also confound the effectiveness of some of the treatments. Did you, either you personally at that point when you began to write this, or your colleagues, your co-authors, did you feel that you had, via personal experience, that you felt that these recommendations were making a difference? That it was that you felt that it was altering the course of things as opposed to being sort of coincidental with an improvement in the patients?
Well, we were in communication with Dr. Didier Raoult in France, Dr. Stella Emanuel in Houston, as well as Dr. Brian Proctor in McKinney, Texas, and then Brian Tyson out in California. They each had experience in over 1,000 patients each. In fact, Dr. Raoult had experience in like 30,000 patients. Mm-hmm. And so they, of course, they are avant-garde and they are ahead of the practice community. They had strong convictions that, in fact, their approach was making a difference. The French published very good observational data that clearly showed that those individuals who received the multi-drug approach had very low rates of hospitalization and death. And so the fair epidemiologic conclusion, in fact, those outcomes did happen. They can't be erased. They happen. So it's either the patients were really good and well chosen, it was the doctors were really good and they're just better than other doctors, or in fact, the drugs do something. But to a layperson, the layperson would want to be one of those patients. They wouldn't want to be one of the other patients who either has different doctors or didn't receive the drugs and have the bad outcome. So selection bias is very interesting. Selection bias is always good for the patient who's part of the selection bias. You may not know what's really driving that good outcome, but there's no doubt about it. Patients who get outpatient treatment across the globe, we've looked at this now in Saudi Arabia, in Bangladesh, in France, in the United States, basically throughout the world, those who get early ambulatory treatment, hands down, do way better than those who get no treatment.
If that's the case, Dr. McCullough, we should be able to see a pretty large effect in a randomized control trial with a fairly small number of patients, don't you think?
Well, it'd be terrific to have these randomized trials. And I have to tell you right now, in terms of outpatient treatment of COVID-19, there is not a single double-blind, randomized, placebo-controlled trial that's conclusive. Not a single one. Even the randomized trials that have been undertaken have been administratively stopped early. So this is particularly true for hydroxychloroquine, which is the most studied agent in treating COVID-19. So about a month ago, we surveyed the literature, and there were 5 completed prospective randomized trials, not placebo-controlled. Subsequently, there's been 2 more that have reported, but we synthesized the 5 that we had at the time and completed a meta-analysis, which has now been published in preprint. But in the prospective randomized trials, all of which were stopped early, and the preliminary conclusion was that hydroxychloroquine did not have an effect, although everything trended in favor of hydroxychloroquine. When assembled, hydroxychloroquine has a 24% relative risk reduction in a composite endpoint of new COVID-19 infection, hospitalization, and death. And when we add the subsequent trials, that point estimate doesn't change. So the point is, if we have small, early randomized trials, they can be just as inconclusive as the non-randomized studies.
Right. There's this, there's 2 randomized control trials that that I'm thinking of. One is the RCT by Dr. Boulware. He's out of Minnesota. They did a randomized double-blind placebo-controlled trial from March 22nd into May, and they looked at, they tried to catch folks early. It seems like a reasonably well done trial. They took 491 patients, they randomly assigned them, and they looked at 14 days to see if there's any significant difference. I'm always a little leery about putting together RCTs together in some type of meta-analysis because the patients differ a lot and whatnot. So there aren't that many of these trials. Any specific issues, with Dr. Boulware's trial where they didn't find any difference in at 14 days?
We looked at the Boulware trial carefully, and we noticed in every single outcome in every single patient group, the hydroxychloroquine patients numerically did better. And the Boulware trial administratively stopped far short of the intended sample size, far short. I mean, thousands of patients down to hundreds of patients.
Right. So there was but that would be the point, right? Meaning, if there is such a significant difference as the observational trials are suggesting, and you're suggesting, especially in the early ambulatory folks, we know that there's larger trials. The recovery trial, of course, in a sicker patient population, I guess one would say that it's too late and HCQ isn't working. So that's why I'm particularly interested in, there's this trial and then there's a Spanish trial, but it wouldn't. Why should you need thousands of patients in an outpatient ambulatory trial like Dr. Boulware is doing? Like, shouldn't 1,000 patients? I think they had 490 patients. Was it 490 patients in each arm or 490 patients total? I'm forgetting now, but it would seem that they should be able to show a large difference in, say, hospitalization or an endpoint that we care about. Why should it only be trending towards if the difference is so big? Meaning, then you're left with the idea that either the effect of HCQ in outpatients is not that big, meaning you need thousands of patients to show a small difference, or that it's ineffective. Is that not? Not?
If the observed effect size, let's just say in general, is settling on a 50% reduction in hospitalization and death, And then the meta-analysis, when we put it together, it comes up with about half that, about a 24% relative risk reduction. That's what we see for therapies. ACE inhibitors reduce rates of cardiovascular events by about 20 to 25%.
Right.
That's what we see. And so I started at the outset that it doesn't appear as if any drug is a magic bullet. And clearly there hasn't been any clinical trial that's put it all together, right? So we don't have a trial of antivirals, corticosteroids, and antithrombotics, which is the current state of the art in the hospital. And I think it was somewhat naive to think that a viral infection could be treated with one off-target drug. Since when do we do that? Even HIV, right out of the gate, we use multiple drugs. Hepatitis C, multiple drugs. Even herpes zoster, we use prednisone and valacyclovir up front. So I think some of this was just kind of poor thinking about, we're facing a killer virus here, and we're going to take a single drug and go step by step. I know that's the standard regulatory pathway, but we're 9 months into this. And in my view, we don't have a single conclusive trial, not a one.
Isn't it the case also, I mean, I'm going from recollection here, that the Boulware trial had relatively healthy enrollees? They were younger and mostly young younger women, healthcare workers, and that you would expect to do well no matter what.
Very low rates. And, that's going to be seen in all these outpatient trials. And that's, the perfect use of meta-analysis is exactly that, is when there's randomized trials, none of them are carried to completion. They're just stopped because of administrative reasons. Some of them not placebo-controlled. None of them had drug monitoring. None of them had any of the quality controls that we'd see in a big sponsored trial. But keep in mind, the level of evidence we need for proven efficacy and safety of a new drug takes years. They're not done in a couple weeks or a couple months. These drugs that we use in everyday medicine, we basically have a chronic disease model. It takes years. Even our infectious diseases, we take a chronic disease model like AIDS and hepatitis C. A pandemic coming at us full bore, my view, as an emergency response, it's a different level of evidence. We need a reasonable probability of success. With hydroxychloroquine, we're currently up to, I think, between 80 and 90 peer-reviewed studies. In those studies where the drug is started early, 100% of them have numerically favor hydroxychloroquine. 100%. And the randomized trials, of course, I've given the results there. Now, in the later stage, once we get in the hospitalization, it's only about 2/3 numerically favor hydroxychloroquine. So it's a modest effect of hydroxychloroquine. That's the reason why we believe it'll need to be in addition to other drugs, and clearly could be replaced. If we had favipiravir, an oral polymerase inhibitor, like an oral form of remdesivir, bring it on. Do you see what I mean? We just have to be agile here. And in our view, we put this together. We submitted it July 1st. We had it published August 7th. I have the second version updated with the ivermectin data as this other suggestion for the antiviral Bex, and that will be coming out in the next few days. The Bangladeshis have basically worked with ivermectin. There's about 8 prospective studies, 1 randomized trial, all of which are positive. Works by a different mechanism. Stanford is testing favipiravir, again, the drug that's already been approved in other countries, basically from preclinical data. It's also used in influenza. It's safe. So it's interesting that some countries have just out of the box said, listen, we cannot flood our hospitals with these patients. We're going to have to go on a reasonable probability of success. Other countries have said, nothing doing. We need proven efficacy, even if it takes years. And the countries who want proven efficacy are the United States, Australia, the UK, some Western European countries, and some South American countries. The unique thing about these countries, despite many of them having great healthcare systems like the United States, we have the worst number of mortalities per million population in the world. Currently in the United States, we're about 800 deaths per million population. India is less than 80. And then, again, you go across these other countries, people said, oh, they're hiding the bodies somewhere. I've been in communication with colleagues in India. I've been there myself. I can tell you they're not hiding the bodies. it's striking the difference. The companies that have adopted early ambulatory treatment are doing incredibly well. They're not flooding their hospitals. They have tons of COVID, but they're not flooding the hospitals. The countries like in the United States and the UK, in Canada, and Australia offer no home treatment as a routine. We're doing terribly.
So tell us a little bit more about the reaction to the publication of your paper from, you know, the big cheeses, so to speak, in healthcare. You're alluding to, I mean, you're mentioning it, but
well, before you get there, Michelle, can I make one point? So the initial trials that showed, for instance, in heart failure, that showed the initial trial was VHEP1, which was hydralazine MDOR. VHEP2 was enalapril or captopril, I'm forgetting now. That's some ACE inhibitor. Those were small trials, and you're talking VHEP1 was about 200 patients in each arm. VHEP2 was 400 patients, and again, because they were looking in mortality, they took a year or so to complete. But I think within a year they showed a survival benefit. In this particular case, we wouldn't be looking for survival necessarily. I mean, even the Bulwer, for instance, trial was looking at symptom severity as well as hospitalization rates. I'm not sure, Dr. McCullough, that we can use the rubric of too high, of needing too many patients. I think if there was a large effect, you should see it even within a small group of patients. I think, I guess where the points that I think do make a lot of sense is that you're saying that, look, HCQ alone is unlikely to have a large benefit, if I understand it correctly. Yes, HCQ alone is unlikely to have a big benefit.
But I have to caution you against the small randomized trials. So I'll give you one in COVID-19. The Israelis did a small prospective randomized trial of vitamin D3. We're talking 100 patients or 120 patients with a 50% reduction in hospitalization and death. I mean, I can tell you, if you look at it, it doesn't have the power. That's what we call alpha error. There's both alpha error and beta error in clinical trials. And so what we're seeing is in these studies is we're just seeing little hints of efficacy. Does anybody think vitamin D has that big of efficacy? No. Does it appear innocuous? Yes. Is it reasonable given the dire situation to entertain it? Why not? But prospective, where we have objective endpoints, the physician decides how much oxygen the patient has. These scoring systems, what have you, they're incredibly biased. Look at the recovery trials program, no blinding. So the doctors know what treatments people are getting and they're assigning the outcomes. I got to tell you what, a poorly done randomized trial, I'm not blaming them. They're doing the best they can in the setting of emergency, but randomized trial has as many threats to validity as non-randomized data. We're looking for anything to suggest a benefit to move forward.
Yeah, I think one of the good points is,
especially when products have an established safety profile. We're talking about unsafe products, that's different. But when something has an established safety profile, to hold back and say, we're 9 months into this and, I want to see more randomized trials. And let's have several million more hospitalizations and hundreds of thousands of people die. And the level of evidence is just not good enough for me. This is going to be, history is going to look back on this. And it may not judge those who are calling for the chronic disease proven efficacy standard. History may not be so kind to them because the consequences are so grave.
No, I think that's a great point that when you don't have any good therapies, and you have some therapies that have some potential for effect, and maybe there's some there's observational data, or even simply clinicians feel based on their vast experience, maybe they've treated thousands of patients. And if they have that feeling, I'm willing to go with it because, again, you're faced with something that you don't have a therapy for. The downsides are huge, with perhaps no treatment. And as you're saying, the side effect profile, as long as the side effect profile is okay, it's kind of like, well, what exactly does one have to lose? But it does kind of set the trap, correct? Meaning it almost sets the trap for ending up being wrong. I mean, ending up being proved wrong down the road, because it's almost like you can't falsify anything it is that you're saying, right? And that's one of the tests of, are we doing the right thing? Is, well, how would we falsify what it is we're doing?
I'm not sure what would happen, Dr. McCullough, if now a clinical trial all of a sudden materialized and showed that HCQ and zinc and azithromycin did not have benefit. Would you regret having published what you published?
No, we're very open about the fact that this is a framework, and we fully expect this to be revised and upgraded over time. So let's say the Stanford group comes in and favipiravir really has the effectiveness. Favipiravir could easily become the go-to drug and not hydroxychloroquine. Keep in mind, that's how clinical trials work, that we use therapies and then we learn from the clinical trials and we adapt. I mean, we used to use furosemide continuously. Absolutely no benefit of that over bolus infusions. Why use it? I mean, so there are constantly things in medicine that get changed and upgraded over time. So I just think we have to be much more permissive to letting science move on. And believe me, big trials roll in, we'll absolutely positively look at them.
Right.
No doubt about it.
But so what has the reception been to your paper? Among academic physicians and people who sort of are big influencers, so to speak?
Well, remember the big influencers, if you will, let's say those on NIH committees or those at the CDC and others, their official recommendation is to do nothing.
Right.
So that do nothing recommendation is not terribly strong. So you can imagine how vulnerable they could feel and how uncomfortable they could feel as there's more and more hospitalizations and death. And the lay public is starting to ask, really, medical community, there's nothing you can do to help the public? Nothing?
Right.
And so the October 9th issue was just pretty recent. The October 9th National Institute's guidelines for the treatment of COVID-19 is now very explicit. It says for COVID-19, symptomatic COVID-19, to do nothing, to offer no treatment to any outpatient, and also even when they're hospitalized, to offer no treatment until patients require oxygen.
Well, it's amazing. I mean, it's really, what explains this about American medicine? And I don't know if it's unique. You mentioned a few countries, but I mean, we know the US and the academic environment. Why is that? Why?
Well, you could ask some questions like, what potentially fatal disease? Now we know when people require oxygen, we've published this from the Coracle Registry, when people require oxygen, the treated mortality rate is 12%, 12. So what potentially fatal condition do we wait to a 12% mortality before we do anything? Do we do that for acute MI? Do we do it for stroke, pneumonia, staphylococcal infections? What infection do we intentionally let progress? The average person is sick for 2 weeks before they come in the hospital to need oxygen. What infection do we treat that way? I got to tell you, that's really hard to explain. So because the NIH guidelines came out about 2 months after our initial paper, people have asked me, well, what do you think? And I said, you know what, to be fair to the NIH, I think a low-risk patient who's under age 50 to watch and wait, like the NIH suggests, is perfectly fine. So I would say the NIH guidelines would be well positioned for the large population of people 50 and below without any comorbidities. I would also say that the NIH guidelines in no way addressed hospitalization as an outcome. The only outcome they considered was death. And so if one has an interest in reducing hospitalization, then one would have to do something different than the NIH guidelines. The NIH guidelines begin treatment when someone is hospitalized and on oxygen. So it's impossible for the NIH guidelines to do anything to reduce hospitalization. The patients and lay people I talk about are very interested in hospitalization. They do not want to go to the hospital. So you can, and the other thing the NIH guidelines did not do is they did not risk stratify based on age and comorbidities. And we know that that model comes together very well.
Dr.
And
McCullough,
without any risk stratification, one really can't apply a logical approach. So we think that what we've put out in the American Journal of Medicine, now followed in Baylor proceedings, really has created a de facto standard, because no other body has really stepped in to fill that void. It's a very big void in American medicine.
do you, Dr. McCullough, do you think there'd be, do you have equipoise to randomizing a patient to a control arm that was nothing? In somebody that's over 50, I guess somebody that's over 50, because I guess your guideline says that under 50 you would not do anything, but would you randomize them to nothing? Is there enough equipoise, or do you think your experience plus whatever data you looked at suggests that it would be unethical to do nothing to somebody?
Well, I have considerable experience in leading randomized trials, and I do believe that they are the pathway to discovering truth with respect to efficacy. So we currently have the protocol drawn up with Emory University and others to do a prospective randomized trial of this sequence multi-drug therapy versus the NIH guidelines, and to bring that forward. And I think I am fairly willing to bring that forward. The acceptability to a sick patient is going to be another thing. I don't know a single sick patient right now that's saying, okay, I'm okay with the NIH. I'll just tough it out until I need oxygen in the hospital.
Right.
I don't know a single patient who would do that.
Which makes me think that the people who write those guidelines and the people who lead, who set the tone, really, I mean, I'm going to mention him by name. I'm not, but Dr. Fauci explicitly said, around the time that your paper came out, said there's no scientific proof that, essentially he threw a wet blanket on the use of hydroxychloroquine. And to me, just for the reason that you mentioned, I mean, what do you tell a patient who now has is diagnosed with COVID, who's 60 or 70 years old, still on the outpatient setting? Do you tell them, just wait, and then if you get sicker, we'll put you in the hospital? So to me, it seems that people who write those guidelines, who set the tone, are not people who really take care of patients. I mean, they're not really involved in the care of patients with this disease. I mean,
Michelle,
if they really were, they couldn't just say, they couldn't tell. I mean, their practice would just wither away. Nobody worked. I mean, their
Michelle,
ratings on health grades would.
But Michelle, right. would you not support Michelle, a physician who went through the data and of course, just as Dr. McCullough picks out the variety of different things that aren't perfect about Dr. Boulwar's RCT, or that the Barcelona, the Spain RCT, or whatever RCT that suggests that the recovery trial, they have their own issues, not blinded, etc. You can see how another physician, whatever biases they have, right, reads the data, looks at Dr. McCullough's guideline, looks at Dr. Raoul Didier's data, and picks apart those studies and says, right, hey, look, these are the problems, and therefore I'm gonna come onto the side of saying, I don't think HCQ works. Meaning, is the ball game big enough to have Dr. McCullough and to have folks that think otherwise? Is that okay, or isn't that healthy?
No, well, it is, but at the same time, it's I'm not sure. I mean, because the intent is to throw a wet blanket and say don't use it, right?
Yeah, whereas I would oppose that.
The intent is not to say. I mean, they could reason. The NIH could issue a guideline saying it's reasonable. It could issue a guideline saying those therapies have not been proven by the standards that we think they should be, but it's reasonable to use them, right? Dr. Fauci could say, the data is not great, but we understand how difficult it is to conduct a clinical trial.
Right.
It's reasonable to use it, and so and the problem is that I'm so happy for your paper, Dr. McCullough, because for the guy in the trenches, it's very hard to go against the people who set the tone for how COVID should be, right? I mean, it's hard to go against the ivory towers. So it's very helpful to have a paper that actually validates, our desire to do something for patients, knowing full well that at the end of the day, we never know for sure that it's, it may or may not help and whatnot, but we're responding, I think, appropriately to a need. And so
let me just respond to that by saying that I think we used aspirin and of myocardial infarction and stroke for about 40 years before we had conclusive evidence that it influenced these outcomes. We definitely lowered cholesterol before we had conclusive evidence. And because we thought it had a reasonable probability of working, okay, that we thought, and all the products that we talk about not only have a reasonable probability of working, they have observational data that are favorable, and they have randomized trial data which are trending towards favorable. So,
what do you think about remdesivir and the antibody cocktails that have now come up? It was interesting. Did you think it was interesting that when Donald Trump, who was a big fan of Dr. Didier's work, and I think had a press conference immediately, when he got sick with COVID and was admitted to Walter Reed, interestingly, hydroxychloroquine was not on the list. Zinc was on the list, and of course the other things were on the list. But do you feel similarly about in terms of efficacy of remdesivir and some of these other agents that have come out, convalescent plasma, for instance?
Well, it's interesting. If you go back to preclinical models, there's been head-to-head studies in the same Petri plates of remdesivir and hydroxychloroquine and chloroquine, and actually they all have efficacy. Actually, hydroxychloroquine works by a different mechanism to reduce viral replication than remdesivir. Remdesivir has the same mechanism of action as favipiravir. But my feeling regarding these therapies is that this virus is a killer. When people end up the ventilator, the Stop COVID program in the United States, which is contemporary, there's still a mortality rate of 25%. The mortality doesn't save 25%, the ventilator doesn't save 25% of individuals. So remdesivir, get after it as early as we possibly can. Convalescent plasma, the same thing. Anything that can help these patients. I guess I have a little bit more compassion than those who say that they want to wait for the evidence and have more hospitalizations and deaths. Do we need to be responsive to new data as it comes along? Absolutely. I'd love to see a panel literally come out with recommendations once a month. Now, the Infectious Disease Society of America has 3 or 4 sets of recommendations now. Not in a single guideline did they address early outpatient treatment.
Though we have evidence even within the COVID pandemic that a default towards doing something it can be harmful, correct? I mean, you're saying that it could be a lack of compassion. I mean, these are kind of, Dr. Fauci and et al. Are kind of dispassionate folks that want a certain bar of evidence. The cost of that be damned, if you will. But one of the biggest things that has probably reduced mortality in COVID is probably this kind of move away from intubate early, correct, and to now. And so that was, again, by the way, that was also something that was we were fed to or by our Italian colleagues in good faith, of course, where the idea was that we had to get control of these patients rapidly and prevent aerosolization, prevent spread to healthcare workers and stuff. And so folks that were coming in, they were happy hypoxic folks. The goal was to just intubate them right away. And so it wasn't felt to be as morbid as it ended up becoming. Is it possible that if we adopt some therapeutic approach in the setting of a disease that we think has no cure, that we could ultimately end up hurting more than helping?
Well, we're 9 months into it. If that was the case, we'd be seeing it elsewhere, right? So we'd see treated patients in France doing worse, having funny side effects. We'd see Saudi Arabia treating it. We'd see Bangladeshis doing poorly on treatment. We'd have some signal that people who got treated do worse. And in fact, we see just the opposite. It almost doesn't matter what we throw at the virus. As long as we do something, it seems to take a little edge off this syndrome, which involves viral replication, cytokine storm, and thrombosis. And so, what's done in the hospital is basically addressing these 3 domains. I'm not surprised about the ventilation thing at all. I think that was somewhat self-serving about trying to reduce spread of expired. The the ARDSNet trial and network basically showed less ventilation is better than more ventilation. So why would that be surprising?
Right.
So I don't think we can translate less ventilation to being better, because we kind of already knew that principle, to outpatient treatment. Right now, what we can see in outpatient treatment across so many countries, and I think now we're up to millions and millions of patients treated. Those patients selected by those doctors who receive those drugs always do better than patients where the country has done nothing for them. Right now, in the United States, by and large, it's patients have had no outpatient care.
And besides, the point about delaying the ventilation was discovered or was concluded without the benefit of a randomized trial, right? I mean, it's just doctors who follow their own clinical judgments and observations, and then decided it was better to delay ventilation.
Let me just say that.
Yeah.
Let me just say that the other thing about making a recommendation, I think it's fair game to make a recommendation on treatments for benefit. But when it's unknown, and to be fair, I really don't know if any of the drugs we're recommending truly are efficacious. All I've said is I think they have a reasonable probability of success. When you don't know, the question is, should you give a hard no recommendation? Do not use it. In cardiology, we call that a class 3 recommendation. Do not do it. We typically only do that for harm. So in guidelines, we say, do not use this drug. It's because we know it causes harm. And I thought the NIH really had an overreach there by do not do something, because they really have to show that hydroxychloroquine causes harm. When we looked at all the outpatient studies in the meta-analysis, there is no signal for harm in ambulatory use of hydroxychloroquine, just like there never was with lupus or malaria. There's no signal of harm. There's no signal of harm for azithromycin or doxycycline. None. There's no signal for harm for corticosteroids. We use it in asthma all the time and other conditions. There's no signal for harm of use of short-term antithrombotics. We use them for DVT prophylaxis all the time. So this idea of not doing something in patients with a potentially fatal disease, I think history is going to look back on that and say, really? To basically give a class 3 recommendation to not do something in a fatal condition? We know the outcomes when we don't treat. We know it right now. We absolutely know it right now. We have millions and millions of hospitalizations. We have hundreds and thousands of deaths, and the case rate is going up. So we know without doing something right now in America, Canada, UK, Western Europe, South America, we know what the outcomes are.
Well, speaking of that, you do this day in and day out. The mortality seems to be less. The outcome seems to be improving despite the this large second wave or whatever you want to call it. Do you see that, in the marketplace among your colleagues in Dallas and where you are, that people are actually implementing, you find that doctors are being more, feel more comfortable sort of intervening early and trying different things?
Sure. A lot of health system based doctors and those affiliated with medical schools are not involved in the treatment of COVID. It's largely been independent doctors that have band together. So now there's nationwide websites, there's nationwide telemedicine, and these doctors are very active. Believe me, the patients want treatment, and they talk. Right. They want treatment. They go on the website, treatment for COVID-19. They can get to one of these sites and get treatment. So our paper kind of broke the ice. We just saw a protocol from a medical school in Virginia that now is going to go ahead and have empiric treatment for all the patients. And I think you're going to see one after another major institute protocols, because we just know this isn't stopping anytime soon, and we know our current approach doesn't work.
Right. This is remarkable, and I want to commend you for at the beginning of our show today. You mentioned Dr. Stella Emanuel in Houston, and in your paper, you also, one of the references is Dr. Zelenko from New York, and both of these individuals are just everyday sort of, doctors in the trenches who decided to grab the bull by the horns, not be intimidated into trying to do what they believe is the right thing, and then with the successes that they've had, try to advertise it to tell other folks, other doctors, look, this works. yet they've been really vilified. I mean, many of them have been, perhaps some of the claims were over the top. I mean, I don't know. I mean, I can see that. But at the same time, I think it's really, this chasm between the ivory tower and the regular doctors, I think is very unhealthy. And so I'm happy that you're an academic doctor. I mean, nobody can question your credentials, and you're very well published. And kudos to the American Journal of Medicine for publishing this. Was there any difficulty in getting this published? I mean, it's a reasonably reputable
It had to
journal.
be, yeah, the paper had to be pre-discussed and peer reviewed. But let me say, this is, it's not unusual to be out and lead in terms of a breakout of a new direction. In cardiology, Dr. Andreas Grunzig is the first one to perform angioplasty with a balloon. He was thought to be crazy. And there are a lot of examples of this. So my message to these doctors who are very much avant-garde is to keep the message on early treatment and really be true to the data in terms of emerging scientific information. I don't think doctors should be opining regarding contagion control and other recommendations that in the setting of an emergency are clearly the responsibility of the regulatory agencies. So in the United States, we have a national emergency communication plan. And for a viral pandemic, it is the CDC. And then all the different agencies follow the CDC recommendations. Outside the United States, it may be the World Health Organization or other organizations. My viewpoint is everybody should get in line with the regulatory agencies on contagion control, because if we don't, we have chaos. And I don't want to hear any other private doctor's opinion on whether or not we should wear a mask or not. If the CDC says wear a mask, and just follow along. So I've been very careful in all my communications. There have been some censorship of people posting videos and other material online. And it's largely because of that, because there actually are rules in place that if someone posts something that's confusing or misleading in the setting of an emergency, there's a responsibility to have that taken down. In fact, that's enforceable through a whole variety of enforcement agencies. So doctors should opine, and we should be free to discuss the science and the approach of the doctor with the patient. But matters of public policy and contagion control, in my view, are a different discussion.
Dr. McCullough, thank you very much.
Thank you so much.